So let's now move on to the mortality indicators in infancy and childhood. So in order to understand the mortality indicators, we can use this diagram that is given in the park, which summarizes all the indicators related to infancy and childhood. So there are certain marks, like this line is 28 weeks of gestation. After 28 weeks of gestation, this is the birth event. So these two events you have to know. Then there is a marking of 7 days, and there is a marking of 28 days, and there is a marking of 1 year. We can do something like this here. So uh, we have uh, uh, certain nomenclature we have to remember. So what is this area? This is if a mortality happens in this period, it is called stillbirth. So between 28 weeks of gestation till birth, it is called stillbirth. Then this whole period till birth till 1 year is called infant. So in any mortality during this period is called infant mortality. Till 28 days is called neonate. So this is neonatal mortality, and this is post-neonatal mortality. Within neonatal, we have two divisions: early neonatal and late neonatal. So with this, let's go with the definition. It would be basically formula would be the any indicator in the numerator followed by generally for developing countries we use live births. For example, in case of stillbirth, uh, in advanced countries, we can have a denominator including total births, that is live births as well as those who are stillborn. So stillbirth divided by live birth into 1,000. So per 1,000 live births is the general definition. So what is the stillbirth rate? So again, we can go a little more technical about this, having understood uh, with regard to the time period that we are referring to. So stillbirth would be so death of any fetus, death of any fetus. So after 28 weeks. So how to know whether it is 28 weeks? Because sometimes we do not have, we don't have the measuring. We don't have idea how much a period of gestation is there. Sometimes history taking is not there. So we can use three things. First is simplest way is 1 kg. If the weight of the child born who is dead is more than 1 kg, then this means it would be more than 28 weeks. This is the one that is used by WHO because this will allow comparison of data across the countries. Second aspect is that if we have better records, then again we can go for 28 weeks of gestation, or we can go for measurement of crown to heel length. If it is more than 35 centimeter, then we can say that stillbirth is there. So this is the stillbirth. Next, a new term is coming. So it is called perinatal mortality rate. So what is perinatal mortality rate? So again, the denominator, we know that in this case, numerator would be late fetal death. So what is late fetal death? That is after 28 weeks. Late fetal deaths plus post-natal deaths of first week. So what is this first week we are talking about? First 7 days, which is called early neonatal phase. So death after 28 weeks of gestation and within first 7 days of childbirth is in the numerator, and in the denominator we have total live births. Total live births which are more than 1 kg. So into 1,000, so per 1,000 days. So now with the declining infant mortality, so right now the best indicator that is available in order to know the health services of a particular community is infant mortality rate. But in developed countries, what is happening is that IMR is going down. So many developed countries are using this perinatal mortality rate uh, as a mechanism in order to gauge how the improvement in health services is happening. Because these two indicators, as we know, there are 2-3 indicators like IMR, the PMR. The IMR is the most important indicator. We will discuss why IMR is used for knowing that the health services of a community are going of a country are good or bad. Now, why PMR statistics are being used by these developed countries in order to measure the health improvements, especially after having known the fact that IMR in these countries has reduced to a great extent. So first reason is that there are two types of deaths included into it: it's stillbirths and deaths of the first week. So there, it has generally been found that the factors that are responsible for these kind of mortality are of a similar kind. So similar kind of factors are there. So first is this reason, and second is that at times what happens that sometimes stillbirth or say early neonatal birth, they are mischaracterized. So misrepresented. Sometimes stillbirth rate is mentioned in early neonatal and early neonatal into stillbirth, because that is it's very difficult to identify what is when the fetus has died, maybe after delivery or maybe within during the process of delivery itself. So if we combine the two, this kind of false data that is created on account of misclassification of the mortality rates, they can get adjusted and give a true picture of it. So that is the perinatal mortality rate we are having. Now let's move on to some facts about neonatal mortality rate. So neonatal mortality rate, NMR, as we know, it is like in the numerator for the first 28 days and the denominator total live births into 1000. Now, the causes of neonatal mortality are mostly something called endogenous. So endogenous causes are there in this factor. And we have to remember one important fact that in most of the world, we are having more of male deaths than female, because male children are more fragile. So in the neonatal period. So that is there. Afterwards, let's move on to what is infant mortality rate. And with infant mortality rate, we will try to identify the causes of neonatal and post-neonatal mortality. We will make a table. We have already understood that neonatal mortality is on account of endogenous factors. And as later on, we will also identify that post-neonatal mortality is on account of exogenous factors mostly because of the environment. So let's move on to infant mortality rate. So this is the most important indicator. So let's go with the definition. Definition is that number of deaths of children less than 1 year of age divided by total number of live births into 1000. That is the definition of infant mortality rate. Now it is universally regarded as the most important indicator of health status of a country. So why such a separate treatment is given to IMR? There are reasons behind it. There are primarily three reasons. First reason is that infant mortality is the single largest age category of mortality. So if we go for a mortality indicator, so within 1 year of age, so it is the single largest age category of mortality indicators. Second aspect is that it is caused by certain peculiar diseases and conditions. So to which adult population is not that much disease conditions, and to these disease conditions, adult population may not be exposed. So in a way, for research purposes, it can be there. And then third aspect is that if we improve health system improvement, it gets reflected very fast in the IMR indicator. So because it is quickly affected and directly by specific health programs, so we can know whether health programs are being implemented properly or not in a particular community. So having said that, let's move on further. So uh, as we know, neonatal period, the mortality is more in case of males, but in post-neonatal period, uh, world over, again, it is more in males, but in India, it is more in females because of social factor. As we know, as we will discuss, there are two factors because there is a neglect of girl child in India. So because of that, this anomaly is there. So if we go, what are the causes of neonatal and post-neonatal? So within infant, we have causes of neonatal and post. We can divide it into neonatal mortality causes and post-neonatal mortality causes. So as we have already discussed, the causes of neonatal mortality are endogenous, while the post-neonatal mortalities are exogenous, mostly on account of the social and economic factors. So it is 1 to 12 months, and it is less than 20 days, 28 days, or what we can say less than 1 month. So what are the causes? So initially, first cause is that low birth weight is there and prematurity, low birth weight and prematurity. Second cause is birth injury. So birth injury and difficult labor. So the obstructed and other types of labor. So that is the second cause. Third cause is sepsis, infection happens. Fourth is congenital anomalies. Congenital anomalies. So these, as we can say, the low birth weight. So it's a endogenous birth injuries like maternal tech. Sepsis also some relation with the like torch infection and other things. Then congenital anomalies are there. Fourth is hemolytic disease. So it's a of newborn. So it's a genetic relation with their mostly genetic relation. Then if there are certain conditions like of placenta and code, like placenta previa, placental issues, placenta previa, vasa previa, and all these things. Seventh, now these are then we have tetanus also. The neonatal tetanus is a famous cause. Then two other causes we know. This is common to post-neonatal also. So acute respiratory infection and diarrhea. So these two are very frequent causes. So as we can see, this is priority wise. So these conditions are majorly responsible. While post-neonatal mortality, first major cause is diarrhea. The diarrheal disease, mortality is maximum. Then acute respiratory infection. These two are the most important causes of post-neonatal mortality. Third is that if there are some other communicable diseases, this is a cause of post-neonatal. Then we have malnutrition. So these are unique set of so because of environment, these things are happening. Then again we have accidents, and then finally sometimes congenital anomalies also manifest a little late. So with this, the causes of infant mortality comes to end. So we have to just think what are the endogenous causes and what are the exogenous causes, and accordingly we can make the list under this. So let's move on to the next one. Under 5 mortality rate. So under 5 mortality it would be children less than 5 years of age divided by total live births into 1,000. So that is the case. Here we have to know that this under 5 mortality rate has been given a special emphasis by UNICEF, and it considered it's a best single indicator of social development compared to gross national income, GNP per capita. So that is the thing that we have to go. Now let's move on to the program. So related to newborn action. So we have something called every newborn action plan. So it has got two targets and five strategic objectives. So let's see what are the two targets. First is we have to end preventable newborn deaths. So there is a clear timeline. So what is the timeline? And preventable newborn deaths by 2035. So we should have less than 10 or less than 10 newborn deaths per 1,000 live births. And then, so that is the clear target. By 2035, we have to reduce newborn deaths, newborn mortality rate by less than 10. So like single digit figures we have to go. And then is, second is ending. So this is preventable newborn. So, and now in ending preventable stillbirths. So why the word preventable is there? Because there are certain congenital anomalies which are very difficult. They have to be. They cannot be prevented because of genetic things. So preventable newborn deaths. So again, we know what are these. Mostly newborn deaths can be prevented. Now, what is this stillbirth? So the target is that by 2035, all should have less than 10. So both the target is single digit. That should be there. So we have this every newborn uh, action plan. So it is a collaborative effort of WHO and UNICEF. WHO and UNICEF. So this was its two targets. Now there are 5 strategic objectives. How will you prevent this much mortality? So there are a package of interventions, and these package of interventions have highest impact. So we can go like x-axis and y-axis. In y-axis, we have to focus on 3 things: community level, what can be done at a community level, then what can be done at a first and secondary healthcare level, and third is referral and tertiary level. What are interventions possible? We have to divide it into, first we have to start with adolescent and before pregnancy, then so that phase of life, then pregnancy, during pregnancy, then during labor and birth, so labor and birth of the child, and then postnatal, and finally childhood period. So during this continuum of care is to be given. So like 5 phases are there. So in adolescent at the community level, so we have to focus on adolescent and pre-conception healthcare and nutrition. Second is that we have to prevent gender violence. So that is the level at community level. So here we have to provide services. Then at the primary level, we have to provide reproductive health services, including family planning. And the second is the same thing at referral level, but of a higher mechanism. So that is then during pregnancy, we community level, we have to go for counseling on birth and birth preparedness. And the primary and the secondary level, we have to go for pregnancy care. And at preferred level, management of some complications arising out of a pregnancy. And the labor at birth level, what we have to do is, so at community level, we can try home birth. So that has to be with clean practices and skilled care. So skilled, trained thighs should be used if at all we are trying for a community level, like home birth we are trying for. So for primary and secondary level, we have to go for skilled care at birth and basic emergency obstetric care. Here, a comprehensive obstetric care has to be given. Then, postnatal period, we have to, at the community level, provide services of essential newborn care and postnatal home visits. So, home visits have to be planned here. And here we have to provide essential services, essential newborn postnatal care of small and sick children. And here the higher level of similar kind of services for childhood at the community level. For child at, so the care of child at home should be there. Then at the healthcare services, primary and secondary, we go for prevention management of childhood illnesses. Their hospitalization in children has to be focused. So at 5 levels is there, and overall there has to be something called intersectoral coordination of all the ministries. So again, moving forward, we have to remember something that large number of maternal and child deaths are on account of something called three delays. So first delay can be that first is delay in deciding when to seek care, and then second is delay in reaching the care, and delay in getting quality service, so quality healthcare. So these kind of delays are there. Next indicator is a child survival index. Survival index. So it is basically is equal to 1000 minus under 5 mortality rate divided by 10. So that is the formula used for child survival method. So that is there. So now let's move on to certain health programs, India specific and with a focus on children. First is IMNCI. MNCI. So the world over we have IMCI, so integrated management of childhood and illnesses, and at the Indian level we have MNCI. So IMCI, the main idea is integration. So what is integration? So it has various meaning at different level. At the patient level, he should receive integrated case management. At the level of point of delivery of health services, so it should be that all the multiple intervention should be given at one delivery point. And at the system level, it would be bringing about together management and support function of different levels of care. So that is there in, so what is the three main components of IMCI? Three components are there. First component is there. We have to improve the case management skills of health staff, and this is done through locally adapted the guidelines. Clear cut guidelines are there, and the focus is on overall improvement in health system. And then third focus is along with health system improvement in family and community systems practices, family and community practices. So that is there. So what it does is it focuses on those most, it doesn't focuses on diseases, rather syndromes, that how it specific signs of that particular syndrome are there. And the diseases that are focused are diarrhea, acute respiratory infection, malaria, then measles and malnutrition. So these diseases are focused. So what are the complete, I mean, say, case management process? It involves 5 steps. First is assess. We have to assess the child not on the basis of on some easily identified signs and symptoms. After assessing, we have to classify them into the categories given, and then we have to identify the specific treatment for a particular classification. And after identification, we have to provide the treatment. And after providing that the treatment, we have to go for counseling and then follow up. Okay, so that is the MNCI focus. Again, India had adopted it for a neonatal period also, like for 7 days also, not only like uh, uh, elderly children. So with this, let's move on to the next thing that we can discuss. So with regard to school health, we have something called midday meal scheme. So midday meal, midday school meal. So the idea is to provide one third of the energy intake and one half of the protein by providing this one supplementary food at the school level. Those children who can get their food, they can get their tiffin, but the others should be provided this thing. And the focus should be on applied nutrition programs. So what is this applied nutrition programs? So wherever possible, UNICEF gardens should be there, where the good practices can be adopted, and some specific nutrients should be provided in order to prevent nutritional problems in the child. So that is there. Now let's move on to something related to disability. So there are 3 terms. We have to know what is impairment, what is disability, and what is this handicap. So basically, what is the impairment is any abnormality, like abnormality, psychological, physical, and anatomical structure. For example, mm, a loss of limb is there. Example, we can understand for loss of limb. So limb has been lost, so impairment is there. Now, because of this abnormality, some activity problem happens. A person is not able to follow some perform certain activities, so this is called a disability. Inability to perform certain activities is called disability. And because of non-ability to perform this activity, a person is disadvantaged by the community. So the handicap is a because of community thing. So we can understand if loss of limb is impairment, a person is not able to walk, not walking is a disability. Then handicap is that because of not walking, he cannot get a job. So that is a handicap. So these three basic terms we have to know. Then certain aspects, what is the mental retardation? The formula is that if it is the IQ index is intelligence quotient is less than, we have various categories of mental retardation. So let's move forwards and come to the next one. Then we have something called Ujjwala Scheme. So Ujjwala Scheme is basically a comprehensive scheme to combat trafficking of children and women. So how it is done is that there are 5 components. First is that we have to prevent human trafficking. How will we prevent? By formation community vigilance groups, adolescent groups, awareness creation, and IEC activities. Second is that we have to rescue those people who are having this, who are victim of this process. Third is that we after this we rescue, we have to go for rehabilitation. And fourth is after rehabilitation we have to go for reintegration. And if there is a cross country issue, then we have to go for something called repatriation. Now, what are the various child placements that can be there? So child placement can be there. First is orphanages we can put, so like special care. Then foster homes are like um, uh, people giving care without giving legal rights. Then we have adoption, where legal rights are also given. Then borstalls are basically these are for those children who are difficult to handle. And then the remand homes. So these are various placements that are possible. Now let's move on to the most important this scheme, integrated child development services. So it is a very old scheme. Ministry of Women and Child Health, Women and Child will takes is the nodal ministry regarding this. And the funding pattern is that 50% of financial expenditure is going by the center, and rest by the state governments. And now for these Anganwadi centers are have been created, and these Anganwadi centers, there are population norms for this. So the for the generally one Anganwadi center is there for 400 to 800 population. However, for tribal areas, even lesser, so like 300 to 800 people, AWC can be Anganwadi center can be created. And there is something concept of Anganwadi on demand. Anganwadi on demand. So here, mm, if a settlement has at least 4 children under 6 years, then but no Anganwadi center, then Anganwadi on demand can be provided. So what are the objectives of this program? Then we will discuss what are the beneficiary and what are the services. First objective is to improve nutrition and health of children 0 to 6 years of age. You remember it is 0 to 6 years, not 5 years. Second is that lay a foundation. So first is improve nutrition and health, then to lay a foundation for proper psychological, physical, and for the proper development of the child. We have to lay the foundation. Third aspect is to reduce mortality and morbidity, malnutrition, and school dropouts. Fourth is that coordination of effective coordination has to be involved, and the capability of mother has to be improved. So what are the there are basically 6 beneficiaries. First is pregnant woman, then we have nursing women, lactating women, then we have other women, then children we have less than. So children we have 3 years and 3 to 6 years. So for 5 and 6th one is adolescent girls are there. So what are the services that are provided? First service is that the supplementary nutrition is given. So again, supplementary nutrition guideline is the same: 1/3 of energy, one half of the protein requirement. Second is that we have to go for immunization services. Third is that we have to provide for health checkups, and if health checkups are properly done, not done, along with this referral services has to be provided. Then some nutrition and health education is to provide, and then non-formal school education has to be provided. So this is IMNCI. With this, RCH chapter comes to an end, and there are only 2-3 topics left of our SPM. We will finish it fast.